Professor de Bernard is important because it was the first surgeon to perform the first hand transplantation in 1998, and with a hand transplantation very quickly was opened the door for facial transplantation. It's 2014, and 1 century ago. It was the First World War. And maybe we can imagine the disfigurement of this soldat and the imagination of the surgeon coming from the world, Howard Gillith, and a lot of surgeons imagine the new technique to restore the face destroyed during this war. And maybe we can make the comparison between the disfigurement 1 century ago and the disfigurement of our patient today is quite exactly the same, but the technique, thanks to the involvement in research, evolved. We have other possibility to restore a good face. Some years ago, it was in 1999, a colleague asked me, this young patient had the lower lip totally destroyed after dog bite, and what we can do to restore a shape and function. And we imagine to use a muscle, the gracilis muscle, and we transplant this muscle in order to repair the lower lip. You can see the operation, but after some time we have a big retraction of the tissue, and we can imagine today how it was difficult to obtain a good growth of the mandible. The result quite was better, but no perfect. In France, in 2002, we asked for the possibility to perform, and the law are quite rigid. The consultative committee for ethics say we don't agree with the facial transplantation because we cannot imagine the future after this operation. And they said, but maybe it could be possible just for the reparation of the nose, upper and lower lip, and chin. And when we receive our patient some years ago, we had exactly the same defect. You can see the patient before, after retraction of the tissue, with this defect of the medial part because we didn't have the possibility to restore the function and the shape of both upper and lower lip. Between 2005 and 2014 in the world was performed 31 facial transplantation. We have the chance to perform 3 of this transplantation. The patient in 2005, this young patient after ballistic trauma in 2009, and this last lady in 2012 with a big tumor, malformative. The picture of this patient just after the dog bite, some months after the ballistic trauma with amputation of the mandible, and this lady I operated with a recurrence of her tumor. And you can see the different shape of this transplantation. On the left side, just skin, mucus, and muscle and fat. For the second patient, in the middle, with a part of the mandible. And for the third patient, skin, muscle, so and so, and maxillary, mandible, and the totality of the tongue. The most difficult problem for facial transplantation is the organization, because we have to divide the team in 2 parts. A part to dissect and raise the transplant, and the second for the patient to prepare the recipient site. In our technique, we use a second free flap in order to survey and to make biopsy after the transplantation in order to survey the possibility of resection. The second team prepared the recipient site. And it was necessary during the First World War. Sir Gillith said, we have to wait for the retraction of the tissue and after to remove the scar. And exactly the same. But we have to dissect every vessel, every nerve, in order to restore not only the shape. The transplantation is not to restore a mask. is to try to restore a face with sensitivity, with movement. Is the goal of this transplantation. And this dissection, this preparation is quite difficult with a larger defect. The most important point is when we cut the vessel of the transplant and we restore the vascularization, we use the term the ischemic time. And the ischemic time is true for every transplantation, must be less than 6 hours. And when the donor is in a city and the patient in another place, we have to go very quickly. So it's a problem of organization. And you can see on this picture this big moment, this important moment when we release the clamp, okay, and when the vessels are sutured and the blood flow come again in the transplant with a modification of the color of the skin of the transplant, the modification of the consistency, the volume. This piece of skin, she was died without life, recover this life thanks the revascularization. With microsurgery, we have to restore every place from the deep until the surface, the sutures, the mucus, the place, the bone, to synthesis the bone, to suture the nerve, every nerve, and from the deep until the surface. And you can see here a lot of people, almost 50 people involved in this transplantation, and you can see the result at the end of the operation. The first patient, the second patient, and the third patient, with this view. And sometimes later, the first patient, the second patient, and maybe we can do some criticism with the second patient because the color of the piece is not exactly the same as the color of the patient. But we have to study the shape in order to obtain the best aesthetic result. But aesthetic result is the first step. The second step is a functional result of this transplantation. For every transplantation, we use immunosuppressive treatment because the risk of rejection are very, very high. Every patient develops after some week a first episode of rejection, and we try to find the good level of the drugs in order to avoid the chronic rejection. You can see we diminish little by little the level of the drugs. We use the stem cells from the donor in order to try to improve the tolerance and to induce maybe some quite chimerism. And now some picture of the other transplantation. Our first, the second transplantation in China, but the patient died after two years. The first transplantation in Paris in 2007 for von Recklinghausen disease, and the first American transplantation in Cleveland, and other patient, and the first patient with burn, unfortunately, he died 3 weeks after the transplantation. Facial transplantation is quite a big problem. The tolerance and the risk of infection and the risk of died. The transplantation in United States before and after. Transplantation in Boston with this patient after electric burn. On the right side, open the patient before. After the first reconstruction with a free flap, and 1 month after the transplantation. With this ethical question, is it necessary to perform facial transplantation for a blind patient? But maybe it's necessary. We have a very interesting discussion with our colleague from Boston. The goal of every reconstructive facial surgery is to restore shape, but restore the function, and to permit the patient to have a quality of life. And you can see here, it was 1 year after the transplantation with Professor Dubernard. She was in a restaurant. Nobody, they don't recognize that she was transplanted. In order to restore the function after the transplantation, to help this patient with a big re-education. You can see this patient doing a lot of exercise. This lady was reconstructed with the totality of the tongue, And 6 months after, she had the possibility to eat quite normally, okay, and she speak. The mobility of the tongue is not perfect, not we have, and she has to be improved. But the result is fantastic for this patient.
Un gâteau à la crème. J'ai perdu ma bicyclette.
In 9 years, just 31 transplantations through the world. The indications are very rare. It's a big challenge for the surgical team or for the patient, and the risks are very high. Firstly, according to the pathology, the traumatic patients, either burn patient or ballistic trauma. For ballistic trauma, the question must be raised either at the beginning or after. We used classical technique after, and it was a question just before, after maybe 20 operations, okay, and 2 years of treatment. And maybe with a transplantation, we can, in one step, just restore the face of this patient. For the burn patient, in order to restore totality of the face, there is a lot of technical question, what we have to do with the muscle of the face. And the problem was for this lady to find the donor who has the possibility to restore the face of this patient before. In such case, for psychological reasons, we don't accept to perform the transplantation. For facial malformations, the problem is when we have to operate. And next week I have to speak about the face transplant for the children. Is it possible to imagine the facial transplantation for the children? For some tumor, some vascular malformation, like a birth case, this young patient with von Recklinghausen disease, or this other young patients with venous malformations. We avoid, for this patient with von Recklinghausen disease, we don't accept to perform, for psychological reasons, to facial transplantation. For arteriovenous malformations, it's a big problem because this malformation, arteriovenous, can be vascularized not only by the external carotid system, but together by the internal carotid system. And if we perform transplantation, maybe we have a recidive of this disease into the transplant some months or some years later. And the indications are very, very difficult. This third patient, I operated in 2003, firstly. She had a very, very often hemorrhagia, and the vital prognostic was raised for this patient. We put just a latissimus dorsi free flap. And after some years, we have recidive of this malformation, and you can see into the free flap, the arteriovenous, and with a lot of bleeding. Why we decided to propose a much larger amputation of the face and the restoration, and you can see the patient sometimes later. Morphologic and functional result. But for malignant tumor, we think due to the risk or development of new tumor according with the immunosuppressive treatment, we think we have not to use facial transplantation. One example in Spain, and the patient died. But the question is raised for larynx transplantation. We received this patient some months ago. She was operated for carcinoma of the floor of the thymus 15 years before, without a specific cancer for the lady, without virus, but without tobacco. She was operated with irradiation. She developed X-ray necrosis, and today, like that, she cannot eat through the mouth, and she has a lot of difficulty to speak. We have the development of infection and retraction of the tissue. And for us, the question is 15 years without cancer. We don't have any other possibility to improve the face of this patient. You can imagine what we can obtain after one operation, but behind there is a vital risk with immunosuppressive treatment for this patient. The limit of facial transplantation. The limit for the baby, the minimal age, and if we can find a donor for a baby. For example, we received some years ago this young patient with a congenital nevus of the face, with involvement of the bone in the deep. Facial transplantation or not? And we don't agree, and we use classical technique. The problem of blind patient, before we thought, no, why facial transplantation? And for example, we received this patient after shotgun trauma with epitasis for the nose. He is blind. He received more than 30 operations, but I cannot accept today that we do a facial transplantation for the failure of the classical technique. Either we start at the beginning or we use just classical technique. The limit is for this patient, shotgun trauma, more than 30 surgical times. And Italian people reconstruct his life normally, but with bad quality. The problem of psychological aspect in order to choose the good patient. What is interesting is the first lady, Isabel, when she said, without face, we are nothing. You give me again an identity. And you can see here, the problem at the end is to find the donor. For the first patient, we were waiting more than 2 months. For the second patient, more than 7 months. In France, we have the duty to restore the face of the donor in order to present the donor to the family. And during the operation, we have to print the face of the donor and to create a mask and to restore the mask of the donor. The future, it is interesting because just before we received some information about new technology and the involvement in research and in the usage of stem cells and the creation of the new tissue, maybe in the future there is no transplantation anymore. It's totally necessary for everybody to be involved in a research program in order to create tomorrow or later new tissue and why not new organ to restore a piece of the face. The future of the transplantation, like you, we create in France our institute, the Facing Faces Institute, in order to try to develop this new technology. It's no possibility to perform transplantation if nobody accepts to give a part of her face. Thank you.
This is absolutely brilliant, creating the world's first ever research centre dedicated to this most socially sensitive part of our body, which will collect major data and organise research to improve patient treatment worldwide. Well done, Saving Faces.